What are the chances of leaving hospital alive after cardiac arrest? This meta-analysis includes 141 eligible studies, analyzing a couple of million out-of-hospital cardiac arrest cases worldwide over 40 years. According to this meta-analysis, 29.7% of patients reacted positively to CPR. They passed ROSC, which means that their hearts start beating again as a result of performed CPR. When someone's heart stops outside a hospital and an ambulance does not arrive immediately, for many patients it is too late to receive help. The hearts of 70.3% of patients could not be restored to beating. This is sadly a high number, but kind of understandable. Okay, so we have almost 30% survival rate, right? Well, not so fast. The same meta-analysis showed a survival rate to discharge from hospital, and this statistic is dramatic. It is only 8.8%. Despite the restoration of the heart rate, patients die over the following days. Let's look at why this is happening. Without oxygen, the metabolism of neurons is changing. This alters many of the chemical processes carried out by neurons. Despite the restoration of oxygen supply, the metabolism will not return to its starting point. What's more, if we replenish oxygen, this oxygen may do even more damage to the metabolically altered system. Many of these process changes happen at the same time, and they don't necessarily depend on each other. What are they? Sodium starts to build up inside the neurons because it is not being pumped out. Water rushes inside the neuron to try to dilute that high concentration of sodium. This causes the neuron to swell and can even cause it to rupture. Calcium begins to build up in neurons. Such excess is toxic and above a certain level triggers the apoptosis or programmed cell death process. Each cell is genetically programmed to die someday, and too much calcium leads, metaphorically, to pressing the red instant self-destruct button. Mitochondria self-destruct and kill whole neurons. The altered metabolism causes an increase in the amount of free radicals. Free radicals are oxygen molecules with a missing electron. To complete the missing electron, they kind of steal it from the environment, so they destroy the cell by tearing electrons out of it. This is what we call the ischemic damage cascade. These processes begin when there is no oxygen flow to the brain. They last for several days and can be fatal. These processes are responsible for the patient's death, usually within 12 hours to 3 days after successful CPR. Even if the patient survives, very often they develop irreversible neurological damage. The higher the body temperature, the faster the metabolism. As a consequence of fast metabolism, all these processes happen more rapidly. By lowering the patient's body temperature, we are able to slow down these processes and sometimes even completely block them. This study showed that for each degree Celsius higher than 37 degrees Celsius, the risk of an unfavorable neurologic recovery increases, with an odds ratio of 2.26. Whenever researchers ask themselves whether fever after cardiac arrest is fatal, the answer is yes. Ischemic damage cascade processes are so intense that in 1/3 of patients, ischemic fever occurs after the currently recommended cooling period of 24 hours. For many decades, a lot of studies on animals showed that if you lower an animal's core body temperature after cardiac arrest, the brain recovers better, and therefore the outcomes are improved. This was then translated to the human environment through clinical studies. Targeted temperature management, TTM, was previously called therapeutic hypothermia. The general idea is to cool patients down, keep them cooled for a period of time, and then re-warm slowly to normothermia. Targeted temperature management improves recovery from cardiac arrest, improves brain survival and outcomes. The idea of the therapeutic power of cold comes from decades of laboratory research on animals, which has been strongly documented. The 3 landmark clinical trials on humans were performed at the beginning of the 21st century. These trials randomized patients after cardiac arrest into a control group and a group where therapeutic hypothermia to 33 degrees Celsius was applied. The 33 degrees Celsius was established based on laboratory data as the best therapeutic window for human cooling. Patients were out-of-hospital cardiac arrests cases with ventricular fibrillation arrest, so only people with shockable rhythms were studied. This is actual data from one of the studies. The bottom curve is the cooled group, and here we can see temperatures of the not cooled control group. When the outcomes are examined, a remarkable thing can be found. The survival rate of cooled patients was much higher than in the control group and with a much better neurological outcome. So it's not just the survival percentages, but a better neurological condition as well. These 3 studies were made in different places, in different environments, by different protocols and arrived at similar results. That means these findings are reproducible irrespective of where they are conducted. The HACCR study looked at patients' conditions 6 months after discharge. The object was to see if benefit was only temporary, and the finding that it was a long-standing benefit. All but 1 patient were alive 6 months later. The 3 studies looked at people with shockable rhythms. So the question that remained for many years was, what about people with non-shockable rhythms? There are different initial cardiac rhythms of arrest. It can be shockable or non-shockable, and they have very different implications. So the question was, does cooling only work for shockable rhythms, or could it work for any rhythm of cardiac arrest? It took over 15 years to do this study. This was a multi-center trial of cooling people after cardiac arrest when they had non-shockable rhythms. The finding was that survival was also improved in non-shockable rhythms. Here you see CPC scores, Cerebral Performance Category Score. Scores were better in cooled cases. So this confirmed the prior studies and extended the conclusion that you can have any cardiac rhythm and by cooling patients do better. Current guidelines now recommend TTM for post-arrest care with any initial arrest rhythm. Another landmark study regarding therapeutic hypothermia is the Nielsen study. A number of studies have shown that the lack of oxygen causes neurogenic fevers, which increase brain metabolism, increase brain swelling, accelerate the death of neurons, and this can be really harmful. So they said, hold on, cooling is great, but maybe most of the benefit of this therapy is not actually cooling, but instead aggressive fever avoidance. So in the Nielsen study, they found identical outcomes at 33 or 36 degrees. Basically no difference. A surprising result in 2013. The medical environment really struggled with this, because for years there had been this very nice and tidy story that cooling worked in animals, that cooling worked in humans for VFib, then that cooling worked in humans for every rhythm. And now the result in the Nielsen study was saying that maybe we don't need to cool at all. Maybe we just need to aggressively avoid fever. In the Nielsen study, they compared 2 patient groups. One of them was cooled to 33 and the other to 36 degrees. Interestingly, in the study, they had very high bystander CPR rates. The national average in the United States for CPR survivors is about 30 to 40%, while in the Nielsen study, it was about double that regarding bystander CPR. This study was made in Scandinavia, where most citizens are trained in first aid, which explains the high bystander CPR rates. When patients experienced cardiac arrest, the witnesses immediately began performing CPR. These patients' brains were deprived of oxygen for less than the world average. Therefore, it can be assumed that patients in this study were on average in a much better initial condition than the world average. Here are the HACCR and Bernard studies I showed you before. These studies compared a group cooled to 33 degrees Celsius with a control group that was not cooled in any way. More importantly, observations showed that the control group developed a fever of around 38 degrees Celsius. And here we have the Nielsen study. By design, it did not allow patients to become febrile. They looked at 2 groups. one kept at 33 and the other at 36 degrees, and both of these groups were maintained at that temperature with surface temperature management devices. So the otherwise inevitable occurrence of fever was mechanically prevented. What was missing in the Nielsen study was a control group with no temperature treatment. So these studies are not directly comparable as they are designed differently. This trial did not test the same hypothesis. Many people doing coffee table reading of only the abstract misinterpreted this study. The results in the Nielsen was that 33 and 36 degrees is equally beneficial. In the field, the assumption was made that, since 36 degrees gives the same survival rate as 33, then cooling patients is not needed at all. Due to the lack of a non-cooled control group, an important fact was overlooked. Both 33 and 36 degrees Celsius groups had doubled the surviving rate in comparison with people not cooled at all. This is because keeping someone with surface temperature management devices on 36 degrees Celsius is still mechanically avoiding the fever. If this wasn't already complicated enough, in 2021, Dankiewicz conducted an identically designed study in which he compared the results of the cooled to 33 degrees Celsius group with the group kept at 37.8. The main idea was, if it is about aggressive avoiding fever, maybe we can just do therapeutic normothermia instead of cooling people and we will get the same benefit. Now, much like the Nielsen study, an incredible rate of CPR bystander survivability was registered, almost 80%. So again, it can be assumed that all patients in this study were, on average, in a much better initial condition than the world average. Again, if we compare these results with not cooled patients, the survival rate is almost doubled. It was again proven that using a surface temperature management device to prevent the occurrence of fever practically doubles the chances of patient survival. So we have a group of therapeutic hypothermia studies proving that cooling patients to 33 increases the survival rate. Then we have a group of studies saying there is no difference between cooling and maintaining normothermia. From that point on, the procedure of therapeutic hypothermia was renamed to TTM, Targeted Temperature Management. So the question is, now what do we do? The clinical world of critical care cardiology and emergency medicine are really struggling with this. Well, you have to look at the patient population. What is the studied population? Is it randomized? One of the most important questions is, if findings can be applied to the general patient population. The fundamental point here is that Nielsen and Dankiewicz studies do not say cooling doesn't work. They say that for a select population that they enrolled, cooling may not be so important. It was true for a select portion of the kind of patients they enrolled in this study. If you can show that a therapy affects a diseased mechanism reproducibly and robustly, this finding should not be disregarded. In fact, the authors of the article published in the New England Journal of Medicine in 2021 wrote, "Scientific evidence is often poorly implemented or misinterpreted when it is incorporated into clinical practice." After publication of the trial results, surveys from multiple countries indicated that TTM practices had been relaxed or were no longer adopted by many clinicians. Perhaps clinicians misinterpreted the results. In both TTM trials, the overall survival at 6 months among patients who had out-of-hospital cardiac arrest was approximately 50%. This is a remarkable achievement, as compared with the historical value of approximately 25%. There are several studies from the real world, where findings from studies were implemented, which resulted in negative outcomes. Survival rate and outcome were worse due to the misapplication based on a generalization. In addition, there are some newer studies showing that maybe sicker people need lower temperatures. Here is a study out of Melbourne, Australia. This hospital was very brave in that they published very worrisome results when they stated that their hospital changed the procedure and in consequence patients died more often. So what they did was, they had been cooling people to 33. They saw the Nielsen study and said, "We don't need to cool to 33 anymore. We'll just manage at 36. So they changed their protocol from 33 to 36, and their outcomes worsened. They had far fewer intact brain survivors. Implementing the study actually hurt human beings. And they said, "Oh my goodness, we got to publish this as a warning, called other hospitals, and we need to switch back." This was just a clinical observational study, but it is very important as real-world evidence. If one study isn't enough, here's a second. This is one out of Seattle. A very famous, well-respected hospital in Seattle had the exact same experience. They switched to 36 and survival worsened, so they switched back to 33. Sometimes when you take something from a randomized controlled trial and you apply it, maybe the patient's population is different, or maybe it just doesn't generalize. Well, you may get very different outcomes. There were several other studies like this. We all love simple answers. Many therapies reach a compromise, a middle ground, where we say, wow, the world is a little bit more complicated. More studies have shown that maybe it's about patient selection, and this therapy may work for some people and for others not. That's where we are going with TTM. We're going to find that TTM works for some but not others, and it depends on the severity of their injury. Humans are complicated, medicine is complicated, and science is complicated. The following study from Pittsburgh looked at what we call a natural experiment. In Pittsburgh, some clinicians cooled people to 33 and some managed people at 36. Question is, what is better, 33 or 36? In this study, they did some very careful statistical work to line up patients to make sure that there was no comparison of apples and pears. They looked at injury severity, how sick these people were when they came in, or if they were okay-ish. And they found that if patients were really sick, they did much better at 33. If they were less sick, they did better at 36. So this is like the perfect harmonization of all data so far. It's not that TTM works or that it doesn't work. It depends who you use it on, and it depends how sick patients are. A general principle of critical care is sometimes sicker people need a more aggressive therapy. Here we have another study from Japan. They used a different injury severity scale, and they found that the sicker the patients, the more they benefited from deeper cooling. For the less sick, it just didn't matter that much. Based on the popularity of the Nielsen and Dankiewicz studies, many hospitals want to abandon cooling therapy. However, it would be wise not to do so, because through studies, we know that the switching to higher temperature or even abandoning the therapy can actually be harmful. Now, it's not all about whether to cool or not. Many other interesting questions have been asked about TTM therapy. For example, what about the duration? A number of laboratory studies have shown that neurological markers of neurologic injury, neuronal apoptosis, neuronal mitochondrial dysfunction and inflammation of the brain go on for days and days after cardiac arrest, 3, 4, 5, 6 days later. Cooling in clinical practice is generally done for 24 hours. Why? That's because one of the studies chose this as an arbitrary thing. 24 hours. It's a nice round number. It's simple. The question arises, should we cool for longer? This Scandinavian randomized trial looked at cooling for 24 hours versus cooling for 48 hours. What they found was interesting. There was a trend towards a better survival in 48 hours, but it wasn't statistically significant. Unfortunately, this clinical research was pretty underpowered because it had a relatively small group of patients. If this study had 5 times more patients, they might have obtained clinically significant results that would change therapy protocols. Longer cooling is absolutely consistent with the animal literature, but that's not good enough. Powering of studies is important. Anyway, there's an idea that longer cooling may be beneficial. Now, another issue is when to commence cooling. This is a large study that looked at the time window to start TTM after cardiac arrest. So the time from ROSC, the time from getting a spontaneous pulse back, to the time that TTM has initiated. Right here is a frequency histogram of patients and when cooling was initiated. So this just reflects the process, and you can see that a lot of people were cooled within a couple of hours from entering hospital. But for many people, it took 3, 4, 5 hours to get cooling started. That's because these are sick people. There's a lot of stabilization. People are getting central lines and arterial lines and head CTS before cooling. In that study, they found that patients who got cooled right away did better. This is medium quality evidence. It wasn't a randomized trial, but after all, doing a randomized trial of delaying care would just not be ethical. So this is the best we got, and it suggests that starting cooling earlier has a clinical benefit. Lowering the patient's temperature, or mechanically preventing the occurrence of ischemic fever, is applicable in many conditions. It has been shown that athletes recover faster after concussion if their heads and necks are cooled locally. Target temperature management leads to favorable clinical outcomes in patients with certain types of strokes. In some reviews concerning encephalopathy in newborns, we can find the expression that TTM may be considered to be the cornerstone of neuroprotective strategies. It's not a question to cool or not to cool. We have more than 20 years of human studies providing evidence that cooling is beneficial, neuroprotecting, and life-saving. Sometimes really powerful studies have a design bias, or their results are misinterpreted. Other times there is value in the results even if a study is underpowered. The question is, which patients, for how long and how deeply should they be cooled? The discussion is open. One thing is certain, however. Fever should be avoided in patients with the use of surface temperature management devices.